Hello, I'm Dr. Sherry Bucher of the Indiana University School of Medicine, and it's my delight to present to you today on behalf of my colleagues within the mHBB mHBS study. Today we're going to present to you some information regarding the Mobile Helping Babies Survive powered by DHIS2 app. There are three primary objectives to today's presentation. First, you're going to better understand the landscape and the context of the problem that we're addressing. Secondly, you're going to learn a little bit more about the design and development of the mHBS DHIS2 app. And finally, at the end of today's talk, you'll be able to describe key features and understand how mHBS was utilized in the EHBB study. Maternal newborn health is a crucial global challenge. Every year, there's over 300,000 women who die from pregnancy and childbirth complications. And the impact of this challenge on newborn health is even more profound. There are about 2.6 million stillbirths every year and an additional 2.6 million newborn deaths. So altogether, over 5 million babies a year either never take their first breath at birth or they're born alive but they die within the first month of life. This is equivalent to approximately the populations of Chicago, Illinois, and Paris, France combined every year. Almost 100% of these maternal, newborn, and infant deaths occur in low middle-income countries. Sub-Saharan Africa in particular is an epicenter for neonatal death. And the great tragedy of this is that nearly all of these deaths are completely preventable. This is why the American Academy of Pediatrics, in conjunction with other global partners, developed the Survive and Thrive Global Development Alliance. And that alliance developed a set of integrated evidence-based maternal newborn health training and education programs to provide healthcare providers in low middle income settings with the skills, knowledge, and competencies that they need to correctly recognize and manage common complications that often lead to maternal and newborn death. One of the programs that was developed, which is actually the flagship program, is Helping Babies Breathe. This program was developed specifically to train nurses and nurse midwives and other healthcare providers to recognize, manage the complication of intrapartum asphyxia. It provides simulation-based training and education for neonatal resuscitation. The scale-up of Helping Babies Breathe was really rapid. Within the 5 years after the initial launch in June 2010, this program had been adapted in over 80 countries. And on this map, the countries in green, the dark green, all had some level of national integration of the program by their ministries of health or by their professional association partners. Kenya has always been at the forefront of these global Helping Babies Breathe efforts. And this is why we recognize some key challenges very early to the effective dissemination and implementation of Helping Babies Breathe in these settings. For example, one of the challenges that we recognize very, very early is the inefficiency related to paper-based data collection and reporting systems. Paper-based systems can be very cumbersome, they can be expensive, and they're very resource intensive. Paper-based data collection can also create bottlenecks in documentation, time lags in reporting, and can hamper really effective and real-time monitoring, evaluation, and quality improvement efforts. We found that the successive dissemination and explosive scale-up of HBB was outpacing efforts to capture and report crucial programmatic data in an efficient, systematic, standardized, and cost-effective manner. There were some other problems that we noticed with the rapid scale-up of Helping Babies Breathe, both within Kenya and throughout other regional settings. These were barriers to dissemination and implementation. For example, it was found that initial HBB training alone is insufficient to transfer skills that are necessary to save babies' lives to clinical practice. That providers actually need something called low-dose, high-frequency skills practice in order to maintain these key skills and competencies for neonatal resuscitation. And the implementation partners needed improved monitoring and evaluation. They needed tools to link helping babies survive partner resources, and they needed additional quality improvement tools. This is where the promise of digital health innovation comes in. As we're all quite aware, the connectivity, the access to both hardware and software, and to Wi-Fi and to internet and mobile connectivity just continues to increase around the world, including within many low-income, middle-income country settings. So we wondered, how can we harness the power of digital health to address some of these gaps, challenges, barriers, and bottlenecks that we were observing in the rapid scale-up and dissemination of helping babies breathe? We decided to build an app. Initially, this app was called Mobile Helping Babies Breathe, and this app has been through 3 primary phases of development. First, we developed a very initial prototype of the Mobile Helping Babies Breathe app in ODK and conducted a proof of concept test in Kenya. Then, based on the success of that proof of concept, we performed a contextual analysis for the potential scale-up of the app in East Africa. And finally, in our 3rd phase of development, we expanded the functionalities of the app and the toolkit that surrounds it. We now call the app Mobile Helping Babies Survive to reflect the fact that it can support all the Helping Babies Survive programs, not just HBB. And with Bill and Melinda Gates Foundation funding, we've been very privileged to work with partners to perform a pilot test of mHBS in Kenya and Nigeria. I want to talk a little bit about why we selected the District Health Information System as a platform to integrate with the Mobile Helping Babies Survive app. DHIS2 was originally developed by the University of Oslo. It's a very flexible data platform. It helps governments, including ministries of health and other partners like WHO and PEPFAR, to manage health systems more effectively, to monitor data collection and reporting processes, and to improve efficiency and quality of care. It's an open source platform, which means that it aligns with the principles for digital development and digital investment principles. It also integrates seamlessly with other open source electronic health record solutions and provides integrated coverage, not only for data collection and reporting, but for the entire continuum of health information services and resources. Finally, DHIS2 Mobile operates offline. This enables improved reach and uninterrupted activities in locations that have poor or inconsistent connectivity. DHIS2 is also a very flexible and customizable platform. There's 3 main domains that can be utilized within DHIS2. First is for tracking of an almost endless array of customizable indicators, outcomes, and metrics. Events can be scheduled as well as reminders, and also there's a really well-established data visualization and dashboard functionality that comes with the DHIS2 platform. DHIS2 is built for global scale-up and sustainability. You'll recognize here 3 of these panels that you've seen before. Panel A shows the distribution of neonatal mortality. Panel B shows the scale-up of Helping Babies Survive programs. Panel C shows the adoption of DHIS2. And Panel D is new. That shows the adoption of the Every Newborn Action Plan. What these 4 panels collectively demonstrate is that by integrating apps within the DHIS2 platform, you are also building the potential to have seamless integration with local, national, regional, and global partners that are all working toward the collective goal of trying to reduce maternal and newborn mortality. Now I want to take a moment to talk about the features, functions, and utilization of the app within the specific context of the EHBB mHBS study. There were three specific aims to our study. Aim 1 and Aim 3 are going to be discussed in more detail by Dr. O'Moran at the Lunch and Learn session on August 11th. Today, I'm going to talk to you about specific Aim 2, which was integration of the EHBB and mHBS apps and linkage of those apps to the DHIS2 platform. The purpose of this was to support comprehensive data collection of key metrics and indicators related to educational, clinical, and project outcomes. First, just a very brief orientation to the framework for the study. Our main question revolved around whether digital health tools can support the retention of neonatal resuscitation knowledge and skills among healthcare providers. 274 nurse midwives from 20 health facilities in Kenya and Nigeria participated. Each of these nurse midwives received in-person Helping Babies Breathe training. They were all provided with a mobile phone that was preloaded with the study apps. Each of these nurse midwives was randomized to one of three groups, which are shown here. Each person received only one of these interventions. Every hospital was provided with neonatal resuscitation practice equipment, and the nurses were evaluated at 1, 3, and 6 months after the initial in-person HVB training for their retention of neonatal resuscitation knowledge, skills, and competencies. Research assistants utilized the mHBS DHIS2 app for all the study's data collection activities. And we also utilized Crashalytics to track app usage metrics. What we developed was an integrated tool, Mobile Helping Babies Survive. It's a training, education, data collection, and reporting app specifically built for healthcare providers in low middle income countries. We utilized iterative, agile development processes, and we conducted extensive usability testing. mHBS DHIS2 is a Java-based tool built within the DHIS2 mobile platform. It operates across a very wide variety of Android devices. It supports offline data collection. Data are stored to the device and uploaded once the end user is in an area with network connectivity. mHBS also links with other apps, both internal apps within the toolkit and external partner apps. We've also built privacy and security considerations into our development efforts. The app is GDPR compliant. And specific to this research study, users were assigned unique IDs and PIN codes, which unlocked permission-based access only to specific features and functions, depending on what their role was in the study or what group they'd been assigned to. We developed customized data visualization and dashboard features for our project management partners. And as previously mentioned, we use Crashalytics to collect app usage metrics. There were 3 internal apps that were all seamlessly integrated and were accessed through a single portal. These included the Tracker app, which was used primarily by research associates to collect data, the Trainer app, which was utilized by all study participants to access the digital interventions that they'd been assigned to, and the Aggregate app, which provided dashboards and data visualization to our partners at University of Washington. There were some specific functions and features of mHBS that were just for research assistants. For example, they were able to enroll participants according to country, facility, and Helping Babies Survive program. They were able to manage their field activities by searching enrollees and tracking events. They utilized mHBS DHIS2 to conduct HVB educational evaluations and to observe deliveries to assess if HVB knowledge had translated into actual clinical practice. For the nurse midwife participants in the study, they had access to their assigned digital training group for the entire 6-month period via the mHBS app. They were also able to conduct self-directed HVB knowledge checks and report deliveries, resuscitation, stillbirths, and HVB practices throughout the study. We have some additional QI tools that are built into the app that were deactivated for the eHBB study. And of course, through mHBS, any nurse midwife who was assigned to the virtual reality training group was able to access that mobile-based virtual reality training simulation directly from the mHBS app. We also developed customized dashboards for our project management partners. And we were able to track app usage and crash history in real time. What we're showing you here are some screenshots both for the tracker and the trainer app. The key finding from this part of the study is that the mHBS DHIS2 app is very robust and extremely stable across time, continents, countries, and end users. For the 12-month period after the app went into production, there was not a single instance of any crash. It remained steadfast throughout the course of the study. So what did we find? Did we achieve what we set out to achieve with specific aim 2? In a word, yes. We now have multiple forms specific to HVB that are available in the mHBS app. Multiple users across multiple roles can utilize this app according to permission-based access. People can have access to multimedia educational and training resources, and we've linked mHBS with DHIS2, which adheres to the free open source software principles. This app can be easily expanded to support other maternal newborn child health programs and to support a variety of functions across research, training, and quality improvement initiatives. There's also additional value added beyond the scope of specific aim 2. For example, we were able to link external partner resources and apps within the mHBS platform. And we have found it is an extremely stable, robust, and secure platform. We think due to our thoughtful design, rigorous development, and also due to our purposeful development of a secure, private, GDPR compliant system. Our vision is to eventually scale up mHBS to support all of the local, national, regional, and global partners who are working so hard over the next 10 years to achieve SDG health targets. If you want to learn more about the app, please don't hesitate to contact myself or my collaborators on this project. We have a wide variety of presentations and publications that may be of more interest to you. This project could not have been conducted over the many years in the phases of design and development without our incredible partnerships. Thank you so much for the opportunity to present today. If you want any more information about this app, please contact myself or my colleague, Dr. Saptarshi Perkayastha. I look forward to speaking with you on August 11th when Dr. Rachel O'Moran, the principal investigator of the eHBB study, presents our study results in full. Thank you and have a great day.